you already knew that.
Yeah, and it's actually going to be fun to go through in a sick and twisted way, but it's going to be fun to go through.
Dr. Sanders?
Yes.
If you could just remind everyone once the meeting starts to put themselves on mute. That way it cuts down on feedback.
Okay.
Yep.
Will do. Good afternoon, everyone. Thank you for joining Florida Medical Directors Association, Society for Post-Acute and Long-Term Care Medicine Journal Club on May 23rd, 2018. Our session today will run for an hour so that we may have time for discussion. If you have any questions during the presentation, please send them to us via the chat box and we'll go through them at the end. Today, our presenters will be Dr. Marianne Novelli and myself, Dr. Diane Sanders-Cepeda. While we are presenting,
Thank you so much for joining. Today we are going to be talking about we're actually going to be talking about the poop emoji and its role in the clinical practice guidelines for C. diff in adults and children. This is the IDSA update that was completed in 2017, and it's also the Society for Healthcare Epidemiology of America. So these are our sources for guidelines when it comes to infectious disease. Dr. Sanders, if you could do the next slide, please. So, as Homer Simpson says, C. difficile, C. S. difficile. Next. Okay, so exactly what is C. diff? C. diff is a gram-positive anaerobic spore-forming bacillus. The name comes from Clostridium, comes from Latin, from the word for spindle. You remember the spindle that pricked Snow White, episode Snow White? And then the species is difficile. It was initially hard to isolate and grow. Difficile means difficult. Next.
It was Sleeping Beauty, not Snow White.
Oh, thank you so much. I appreciate it, Sleeping Beauty.
Dr. Fine, thank you. One Disney.
No,
Okay.
no, please, absolutely. And actually, that reminds me, if you have a question or a comment, please jump in, or if you don't want to jump in, you can use the chat box for comments. We will try to answer questions as we go, and we've deliberately made this long, as Dr. Sanders said, so that we have an opportunity to really discuss how this impacts us in our environment. So why is this important? The C. diff cases are increasing, and you can see the number of C. diff cases that are nursing home onset. This is data from a paper that we'll be sending out after this session. It's Les et al. In the New England Journal of Medicine, and it's a review of C. diff in the United States. It's a very good paper. But these are data from CDC that they commented on. So next. So these, in 2011, there were 453,000 new infections. Almost 300,000 of those were in healthcare facilities, and 100,000 of those are from long-term care. Importantly, even greater than 20% of the, and it's called C. diff infections, that's what CDI is for. They used to be called C. diff-associated diarrhea, and that's an older term. So CDI, 20%, greater than 20% of those started in long-term care, and 20% of even the hospitalized C. diff cases had started in long-term care. Next. And if you look at this table, again from Martha et al., you'll see that the elderly form the large percentage of the cases of the nuisance of C. diff, and that is highlighted for you in that column of greater than or equal to 65 years old. Next. So do people die of C. diff? It's not just a diarrheal illness. There were 29,000 deaths in the U.S. in 2011. Mortality is reported as 4.5% to 16.7%. There's some sources that go even higher than that. And if you have C. diff more than once, and you have a recurrence, and we all have patients that have C. diff over and over again, you have a 33% increase in risk for mortality in 6 months compared to people who had C. diff only once. That is really substantial. So C. diff is not a benign illness. Next. So why have they started out with new guidelines? It's surprising. The last guidelines were done in 2010. And as quickly as things change, it's surprising that it took them 7 years to come up with new guidelines. But the burden of C. diff is increasing. And C. diff is the most common healthcare-acquired infection. Now, that's really fast, hospital-acquired infection. That's even more than MRSA. I think we all have a high index of suspicion of MRSA, and we all worry about MRSA, but C. diff has overtaken MRSA in hospital-acquired infections. There's new testing modalities. We're going to be talking about that. There's no new treatment modalities. We'll be talking about that. And, of course, there's increased resistance, which is never a surprise. So how do we define the populations? And we need to talk about where these happen. Now, you remember that pneumonia was also defined by the locations that happened. C. diff has also gotten these kinds of definitions that allow us to really look at the epidemiology of C. diff. So bear with me while we go through this. We have several different places that C. diff occurs, and that's how they do the epidemiology. There's healthcare facility onset called HOCDI, and it's more than 3 days after admission to the healthcare facility, and healthcare facilities, long-term care is included in healthcare facilities in this definition. Community onset healthcare facility associated, it's occurring less than 28 days after, so less than a month after discharge from a healthcare facility, or less than 3 days after hospital admission with an overnight stay in the hospital prior to 12 weeks. And community associated is no overnight stay in a healthcare facility in the prior 12 weeks. Next. So just keep those in mind. So who gets C. diff? Not surprisingly, it's our population. It's the elderly who are over 65 years old, female, Caucasian, recent antibiotics. Interestingly enough, kids can get C. diff, and this guideline, although we're not going to touch on it, is also associated with treatment of pediatric cases. Community dwellers are getting C. diff, so you can have community dwellers who will present to you. So if you're doing any outpatient work, keep that in mind. Organ transplant patients, so immunocompromised patients, inflammatory bowel disease, CKD patients, and ESRD patients. Next. Okay, Dr. Sanders, if you don't mind, can you go through all the antibiotics?
So, to be very comprehensive, when you ask the question of which antibodies cause C. diff, all of the above. We see particular increase in patients who receive third and fourth generation cephalosporins, fluoroquinolones, the carbapenems, and clindamycin. I believe when I went through medical school, clindamycin was the answer for everything, but as stated, all of the above is the correct answer. So it's very important for us to have a high suspicion for this. When we're looking at how long your risk for C. difficile is elevated after antibiotics, the highest risk is in that first month after the antibiotics are stopped, and it lasts for at least 3 months after antibiotic exposure. So that's a lot longer than we think, and that's why antimicrobial stewardship is so important in our space.
Dr. Sanders, if I may comment for just one moment, and it certainly is more. It occurs more with the longer time frame that you've had antibiotics, but C. diff has been reported even after a single dose of antibiotics. So that person who went in for an operative procedure and got one dose of pre-op antibiotics is still at risk for C. diff, and that was 3 months ago. So they may not recall that, or it may be hard to find from the records whether they had antibiotics or not.
Yes, and Dr. Novelli, if you could go ahead and proceed with talking about testing.
Okay, so who should you test? I think it's tempting to test everybody with diarrhea, but let's talk about exactly what the patient is. So the patient that you want to be testing for C. diff is the patient who has new onset unformed stool, so more than 3 in 24 hours, and it's unexplained. If you could go to the next one. You don't test those patients who have diarrhea clearly attributable to underlying conditions, so inflammatory bowel disease, enteral tube feedings, cancer chemotherapy, and look for laxatives, because if you started to give a patient laxatives and they suddenly have diarrhea, sometimes it's also unclear from the record that they've started to use laxatives. So look for that, and then it's appropriate diarrhea. Now, keep in mind that patients with inflammatory bowel disease, for example, have a higher risk for C. diff, and laxative use doesn't preclude that the diarrhea could be from C. diff, so they could be true, and unrelated. So you have to use your clinical judgment in terms of when you're going to be testing for C. diff. But this is a guideline. So just make sure that if you've got diarrhea, you want to say, is there a good reason that the patient is having diarrhea? And do they look sick or not? So, but just keep those things in mind when you're sending a stool for C. diff. Next. Okay, what stool do you send? The soft serve ice cream kind of stool. And that might be a compelling image, but nevertheless, it's actually described in the guidelines what kind of stool you want to send. You want to send a stool that is liquid or soft, and so you want a stool that at least takes the shape of the container. So we have a good description in the guidelines of what kind of stool to send. Do not send foreign stool. And as an additional comment, you can do a fecal swab for those patients who have an ileus that is suspected to be due to C. diff, but that's kind of beyond the scope of what we're talking about, but that's the exception to what they want you to send. And the guidelines are actually encouraging labs to reject any form stool samples that they get that are being sent for C. diff testing. Next. So how do you test for C. diff? Well, you can get Angus, and Angus has actually been trained in Canada to sniff out C. diff. He is a C. diff sniffing dog, and if any of you have had the pleasure of smelling C. diff, you know that it has a particular odor, but there is actually a dog that has been trained and certified as a C. diff smelling dog, and he is apparently quite accurate, and he will lay down when he finds some C. diff smell. So absent our ability to get Angus, we can use these other testing methods. So if you can go to the next slide. They're complex, and we're going to go through them for a little bit, but you have to, and I would urge you to check with your infection control, infectious disease consultant, and your lab to make sure that you understand in your institution what the process is for C. diff testing. Next. So, the guidelines actually talk about which test to use, and the best performing test is what they recommend is algorithm. So the nucleic acid amplification test, that's the NAAT test, is extraordinarily sensitive and can result in false positives. So they've come up with a recommendation, and that's in figure 2, which we're going to go through in just a moment. Now keep in mind, look at this, it's a weak recommendation, low quality of evidence. That speaks to the complexity of testing for C. diff. It's not as simple as we might want to hope for. So if you can go to the next one. These are the kinds of tests that are available. The tests are the toxigenic culture. Unfortunately, that takes up to 96 hours. The nucleic acid amplification test, again, very high sensitivity. The glutamate dehydrogenase, it's a common antigen in C. diff. And the cell culture cytotoxicity and the toxin A and B immunoassays, look at how the poor sensitivity on that and only moderate specificity, and that's measuring free toxins. So again, we have to couple these tests to make sure that we're getting correct tests. Next. The most sensitive test is the nucleic acid amplification test or the multi-step algorithm. So it's the glutamate dehydrogenase and measuring toxin, or then arbitrated by using the nucleic acid amplification test.
All of these, which tells me that you don't know what you're talking about. Please remember to go on mute if you're not speaking.
Yes, please. Again, this is a weak recommendation, low quality of evidence. Next. There is a little bit of simplification that you can use. This is from the Mayo Clinic. If your patients are wondering, there is an enzyme immunoassay test, and that's the GDH is an enzyme immunoassay test. There's the PCR that checks for the C. diff toxin B gene. There's the cell cytotoxic assay, and that takes a while. So this kind of gives you some language to discuss the testing. Next. This is the figure 2 that we were talking about from the guideline. Now let's look at the first part of it. The clinicians and laboratory personnel agree at the institutional level to not submit stool specimens on patients receiving laxatives and to submit stool specimens only from patients with unexplained or new onset greater than 3 unformed stools in 24 hours for testing for CDI. And I'm reading through that to emphasize that there has to be sort of an institutional level agreement overall about what you're going to do for testing for C. diff. So this is saying that as an institution, you have to agree wholeheartedly that you're only going to send stools that are soft or liquid, that are coming from patients that have true diarrhea, so that's more than 3 stools in 24 hours, and you're not going to send any stools with patients who are on laxatives. So what they're trying to say is that they're going to decrease that pool and increase your pretest probability of what the C. diff is. And that way you alter the sensitivity and specificity of the testing because you're altering the pretest probability. So you're changing that pool. So if your institution has said, yes, this is what we're going to do, then you can do the nucleic acid testing alone. You can go to the yes part of that diagram, and then you can do the nucleic acid amplification of test alone, or the stool toxin test, and as part of that multi-step algorithm. Or if there is no agreement at your institution, and that's fine, you just have to be aware of that, then you have to do the toxin test plus as part of the multi-step algorithm. So this, again, points to the difficulty of testing and the need for sort of a consensus at the institution level, or at least understanding about whether there is consensus or not at your institution about how you're going to be doing C. diff testing. Next. So this is a clarification that came from Pharmacy Times, and I think it helps. It says, if the institution uses only specimens for patients who aren't taking laxatives and have 3 or more unformed stools in 24 hours, then you can use the NAAT. The institution may recommend using a stool toxin test in a multi-step algorithm, or you can say that the recommendation, on the other side of the algorithm, if the recommendation is an initial testing for C. diff with glutamate dehydrogenase, which is followed by a toxin test. Then if the immunoassay comes back negative, then the algorithm recommends follow-up with NAAT. So this is, again, speaks to the complexity of testing. It sounds simple. You have someone with diarrhea and you write on your lab stool for C. diff. You have to be a little bit more thoughtful than that. Next. Okay, just as a kind of sort of emphasis on the differences, this is the algorithm that ARUP uses, one of our labs. So again, they say only test diarrheal stool, and then they talk about the ileus. Don't test asymptomatic patients, or don't test for test of cure, and repeated testing is not recommended. So they do in less than 24 hours, they can do the toxin, and if it's positive, they'll report it as positive. If it's negative, they'll report it as negative, but keep in mind the sensitivity and specificity. Or the glutamate dehydrogenase antigen, and then beyond that, they'll do the toxin, or the reference, which is the culture with reflex to cytotoxin cell assay, and that takes 96 hours. So this is one lab's algorithm. Next. This is Quest Diagnostics' algorithm. So they start with the GDH and they go to PCR, and then they do GDH and toxin positive, negative, and if they have discordant results, so GGH positive but toxin negative, or GGH negative and toxin positive, then they do C. diff PCR, and then they go to say whether it's positive or negative. So this is a completely different algorithm. Again, this points to understanding what your institution has decided to do as a whole, and if there's no consensus, for you to know what is going on. I think someone may have put us on hold, their phone on hold. If someone could take I don't know if we're going to be able to communicate with them. Maybe we can send a chat message.
I'll try to send a chat. Just a minute.
Okay. And we'll go to the next slide while we're doing that. Oh, good. Again, check your institution and lab. Next.
So,
Okay.
yes, so
Dr.
when we are
Sanders,
looking at repeating testing, I think this comes into play for a lot of our patients in post-acute and long-term care, as we're often asked, should we repeat a test in the nursing facility? I like this recommendation. The recommendation is to do not perform repeat testing within 7 days during that same episode of diarrhea, and to not test stool from asymptomatic patients. It's a very strong recommendation. I think it gives us a lot of support for why we are not going to repeat the testing. Our next slide is going through the treatment. I'm going to turn it back over to Dr. Novelli, and we'll go through this together.
Yes. Now, this is if you take nothing else away from this talk, this is one of those things that you should probably have printed out or have available in your back pocket or know how to look it up. The recommendation has changed from metronidazole or Flagyl as the first treatment to vancomycin. So let's look at these step by step. The initial episode for non-severe is vancomycin. That's the first drug, 125 Q4 for 10 days. And that's a very strong recommendation with a high quality of evidence. Interestingly enough, the pediatric recommendations still have metronidazole, but the adult recommendations have changed. And then the other alternative is fidaxomicin, 200 milligrams, and that's deficit, 200 milligrams PO BID for 10 days. And again, that's a strong recommendation. So treatment is for 10 days, which is a longer length of treatment than for a lot of conditions, because the tendency now in the infectious disease literature and practice is for shorter and shorter courses of treatment, but this is a pretty long treatment. You can use metronidazole 500 TID if you can't get anything else as an alternative, but look at the evidence for that and the strength of the recommendation. That's weak. The quality of evidence is high.
Yeah.
So that's a poor recommendation. So if you have an option, start with vancomycin or fidaxomicin. And if you're unable to use that, only for a non-severe episode, you can use metronidazole.
Yeah.
Now,
and I think it's a great recommendation, because it's something that we've been seeing, I think, in practice in the last few years, that the metronidazole has not been working adequately in our population.
And for those of us who've been in practice for a while, metronidazole used to be magic. You would get a patient with C. diff, you would give them 2 doses of metronidazole, 3 doses of metronidazole, and they would feel fantastic. Everything had gotten better. That doesn't happen anymore. So that's a testament to the changing resistance patterns in our populations, in the adult population. So that is something that we really do have to keep in mind. And it used to be that there was a much bigger division between the severe and the non-severe C. diff. Now look at the severe in terms of the recommendations for treatment. That's actually kind of disappeared, because if you look at severe or non-severe, so severe is when you have really a profound leukocytosis, or you have some renal insufficiency with a creatinine of greater than 1.5. It's still vancomycin 125 QID and fidaxomicin 200 BID. The metronidazole drops off, so that's not appropriate for severe infection. So really, they're kind of saying for an initial episode, you want to give vancomycin or fidaxomicin. Those are your choices. In a worst case, when you don't have anything else that you can use, you could use metronidazole, but it looks like they're really shying away from that recommendation. If you have an initial episode that's fulminant, so this is someone who is shocky, who's hypotensive, who has an ileus, who has toxic megacolon, then you're going to go, you really start pulling out all the guns, and you give vancomycin kind of everywhere you can. So you give it oral, you can give rectal instillation of vancomycin, and you can add, and you should add IV metronidazole. So this is all done. You are treating every way you can for someone who has fulminant C. diff, and certainly you can have some people presenting that way, and so this is something that you want to be aware of. So let's talk about recurrence. And this is the bane of our existence. You think you've gotten rid of it, but it comes back. So if you use metronidazole initially, then go to vancomycin. If you use vancomycin to begin with, then you can use doxamycin twice daily. And if you use vancomycin, you can also use a long taper. And you can a vancomycin taper, and you can see how long that taper is. It's a really long taper. And Dr. Sanders, can you comment about the various costs on these?
Yes, so I've recently had patients being recommended for the vancomycin taper, and given the length and the treatment course and my concerns with the delivery in the facility that person was at, I actually recommended the deficit, and when we did a cost analysis, it was actually equivalent to using that prolonged taper. So, there are some things where I know that the newer medication is much more expensive, but just for to make sure we're actually delivering the medication that we are prescribing, we may need to consider that and look at the total cost when we're starting those vancomycin tapers.
This is Dr. Levine.
Okay.
Can I interrupt for a minute? So
Absolutely.
I totally agree with these recommendations. I find our infectious disease doctors with no evidence and data that when they get a recurrence, they push them up to 250 or 500. And it's not, the data that I've read is vancomycin 125 is extraordinarily effective in overkilling the bacteria, and there should be no reason why 250 should be any better than 125. But I've seen them do it. I've seen them add 250 plus flagyl, where, again, I don't know there's any evidence. So I'm glad we have some strong recommendations to say that it's not really indicated to do that. 125 should be adequate, just no matter how long you give it, or switch into something completely different. But don't go to 250 if 125 is not working. It's not.
Yes.
It doesn't make sense to me to do that. So I'm glad that we have some stronger guidelines that we can talk to our colleagues and say you don't need to know 250 doesn't work any better than 125.
Yes. And then for the second or subsequent reoccurrence, again, they're recommending a vancomycin taper or pulse dosing. You could also add rifaximin, the deficit again. But what I thought was very interesting is a strong recommendation, the fecal transplantation, which I remember a few years ago this was very taboo, and now it's seeing it as a strong recommendation. There are many ways to do it. I think it is just very interesting to see how far we've come with these recommendations.
The fecal microbiota transplantation, it can be absolutely stunning in its effectiveness. It is really incredible. If you get over the ick factor, it really is quite remarkable.
Yes, there's several ways to do, and I'm not sure. I think the paper describes giving it via NG tube and the pill form that can be created. So there are a lot of different options that are available to patients nowadays.
Next slide. So when do you start treatment? This is, you can start treatment empirically if you expect a substantial delay. So this is and that's more than 48 hours. Or certainly if you've got fulminant C. diff, you want to start treatment as soon as possible when someone is that sick. So this is kind of the weekend call. So if you don't expect that you're going to get your labs back, say someone starts to have diarrhea on Friday, things are not going to happen until Sunday or Monday, you should probably go ahead and start treatment. You don't want to leave it go for more than 48 hours. If you have, you certainly don't want to start treatment inappropriately. So if you expect your results to come in quickly, then you can wait. But otherwise, if it's going to be 48 hours, which sometimes is not unexpected in our institutions, then you should go ahead and start impaired treatment. Next. Okay, what else can you do? You want to, if it's possible, and someone is currently on antibiotics and they're on day 5 of 7, and they're clinically resolved, and you feel that it's appropriate to stop that antibiotic, you stop it if at all possible. In some cases, clearly you can't stop the antibiotic, but if you can stop the antibiotic, go ahead and stop it. There's been some controversy and some thought about anti-motility agents, and the guideline does address that. And it's interesting how they address it. They say, historically, administering those anti-motility agents, so think loperamide, to patients with diarrhea without consideration or specific therapy for CDI has led to bad outcomes. That's their way of saying, you can see toxic megacolon from using an anti-motility agent. They do state that addition of the anti-motility agent as an adjunct to antibacterial therapy for CDI may be safe, although no prospective or randomized studies are available. So they don't say go ahead and use it. They say, oh, you might be able to go ahead and use it. In my own practice personally, with an abundance of caution, I don't use an anti-motility agent in the setting of C. diff. Dr. Sanders, what are your thoughts on that?
Having seen toxic megacolon a couple of times too many, when I read this in the paper, Dr. Novelli can attest to the fact that I fell on the floor. So I think that there may be safe. Is still, let's stay away from it. I don't agree with. I understand you don't have enough evidence to say it shouldn't be used, but I just think it's a very risky move to start those anti-motility agents. I don't know if anyone else has any other thoughts.
Any other thoughts?
Just sometimes we used to use things like Equestrian to try to find a toxin without really slowing the valves down. But I usually stay away from them also. Just make sure they're hydrated. They get better. So.
Exactly. I think sometimes people feel like they want to control the diarrhea because it's uncomfortable. It's an issue of dignity, but at the same time, the potential downside can be pretty potent. So I don't treat with an anti-motility agent in this setting. Next. Okay, we've heard about PPIs, we've heard about probiotics. The guideline does talk about that. It does say for PPIs, there's an epidemiologic association, and it's actually pretty strong between PPIs and CDIs. And they recommend that you always stop any unnecessary PPIs, so we need to be vigilant for that because of all the other effects of PPIs. But there's not enough evidence to say you should stop PPIs as a measure for preventing CDIs. It's certainly appropriate to stop PPIs for all sorts of other reasons, but either they can't recommend now to stop a PPI to prevent CDIs. And probiotics, this is interesting. I think we were all hopeful that probiotics would be helpful, but the data this time are not sufficient to be able to say that probiotics are useful as a primary prevention of CDI and outside of clinical trials. So they don't have any recommendation for the probiotics at this time.
And I think that really speaks to the integrity of the data that certain studies have come up with. We really need to get better information about the utilization of probiotics.
Okay, next. What's the role of antibiotic stewardship? And the guideline is very powerful in talking about the need to have an antibiotic stewardship program. So you want to minimize the frequency and duration of high-risk antibiotic therapy. And, of course, you look at the antibiotics that are most closely associated with C. diff, and it's kind of, well, gee, that's our whole armamentarium. But it's true, we want to reduce the frequency and the duration of those antibiotics and the number of antibiotic agents prescribed. have an antibiotic stewardship program, and perhaps encourage your institution, if there is not an antibiotic stewardship program, to begin an antibiotic stewardship program. And you should target your antibiotics based on the local epidemiology and the C. diff strains that are present in your institution, if you have that information, and restrict the fluoroquinolones, the clindamycin, and cephalosporin. Consider doing that except for surgery. So consider restriction of the fluoroquinolones, clindamycin, and cephalosporin. So again, be thoughtful about the antibiotics that you're using. When you're able to use an antibiotic that isn't in one of these classes, consider using it. So they are talking a lot about the role of antibiotic stewardship and being thoughtful and judicious in your use of antibiotics. Next. Dr. Sanders, if you can talk about the isolation and infection control.
Yeah, so another big question that we always receive is about isolation. So the recommendation is to accommodate patients with C. diff infection in a private room with a dedicated toilet to decrease transmission to other patients. If they do have to share a room, it's recommended that they be in a room with someone with the same infection. So I do know that it is very challenging when we're trying to isolate these patients in our setting, but they really do need to be isolated, and it's not enough to just have them in a room with another isolation patient. It really has to be the same organism, and for the both patient safety, those patients with other multi-drug resistant organisms should definitely be moved out. It's a very strong recommendation, and I'm very happy that it's in this guideline. Some other things to be known, which I don't know about any of you, but as I walk through nursing homes, I'm always alarmed. There should be gloves and gowns worn when caring for those patients with C. diff. I do think that we're not always very good about this in the long-term care, and I've seen CNAs and nurses and even medical personnel walk in to rooms just saying that they're saying hi and walk out, and we really should be gowning and gloving. It's a very strong recommendation. The other question that I get asked them a lot is, when do you isolate? And you should isolate the patient when you suspect that they have the infection. This may not go over very well, again, with the administration of the building, but it really is, you should be isolated at the time of infection. And I think we're going to run into issues if we don't start thinking that way and treating that way. As far as how long they should be isolated, you usually are supposed to continue the contact precautions for at least 48 hours after diarrhea has resolved. Prolonged contact precautions until discharge. That is not a very strong recommendation. It's a very weak recommendation, and it usually means, like, if that patient has a resolved case of diarrhea, after 48 hours they can be placed back into the population. But some facilities I have seen try to do more prolonged contact precautions until the patient is discharged or until the treatment is completed. So you may want to talk to your buildings about that, but the recommendation is that they are in contact precautions for at least 48 hours after the diarrhea has resolved. Okay, and then we go into the wonderful news about hand hygiene. So they, in this paper, stated that routine hand hygiene with soap and water or an alcohol-based hand hygiene product is sufficient. I've always been taught that alcohol-based hand hygiene products are inferior, so I thought that was very interesting. I still would recommend soap and water just because of the way the spores live, but apparently there is more evidence that the alcohol-based hand hygiene products are effective against spore removal. Dr. Novelli?
I actually read number 3 with interest. Hand washing with soap and water is preferred if there is direct contact with feces or an area where fecal contamination is likely. Now, I hate to say it, but unfortunately, in many of the places that we visit, it's not out of the realm of possibility that we may be in an area where fecal contamination is likely. So I would bear that in mind as I'm going through facilities, and I personally would recommend that hand washing with soap and water is the preferred way of making sure that you've cleaned up any potential contamination as you walk into a room or leave a room. It can be surprising what areas might have some trace fecal contamination, unfortunately. Next.
So we discussed about patient hygiene. The recommendation is to encourage patients to wash hands and shower to reduce the burden of the spores on the skin. I mean, I think that's a great recommendation. As we were discussing this paper, Dr. Novelli and I were talking about what actually happens in the nursing facility when someone is being bathed in the shower rooms. I don't know if any of you had the opportunity to check out the shower rooms in your building, but it's not. I've seen them use the same commode over and over without cleaning as a shower chair. So there's some interest in I think things that we need to do around making sure everything is cleaned appropriately. But I do like that they're encouraging the showering and washing of hands for the residents as well.
And if you read the second part of that, the hands of patients can also become contaminated at a rate of 32%. So they can transmit this to surface, and it could be a factor in recurrence when the spores are ingested from contaminated hands. So it's not a particularly pleasant thing to think about, but we can see where this could happen. So encouraging patients to wash hands and shower could be a useful strategy to reduce the burden of spores on the skin. So there is skin contamination of the C. diff spores. That's what makes it a particular challenge to keep things clean, and it's also part of the reason that it's challenging to prevent recurrences once you've had C. diff. So if you can go to the next slide.
Yeah. So in the nursing home environment, unlike in the hospital where you may see more equipment like disposable stethoscopes, the gloves and the gown should be hung on the door. It's not always the case for every one of our nursing facilities, and the ongoing battle is to make sure we have those disposable patient equipment and to assure that any reusable equipment is properly cleaned and disinfected. It is a very strong recommendation to use the disposable patient equipment and or clean and disinfect all reusable equipment thoroughly with a sporicidal disinfectant. So that is something we definitely should be sharing with our infection preventalists in the nursing facilities to make sure we're appropriately treating our isolated patients with C. diff.
And you might want to look and make sure, like if you have disinfectant wipes, are they appropriate for killing C. diff spores? Because they will comment on that. So you need to look at the labels of the wipes that you're using, like heavy wipes, and make sure that if it says that it's appropriate for killing C. diff spores, and then using the one that will kill C. diff spores and not ruin your stethoscope is a big time. Okay.
And Dr. Novelli, if you could talk about the long-term care challenges.
Certainly. So in long-term care, this was actually an interesting blog about C. diff infections in nursing homes. And I think we can all relate to this because this is not an unlikely scenario. Marge uses the toilet without washing her hands, so she has C. diff. She's used it, and she's had diarrhea. And fortunately, she's been able to use the toilet on her own, but she doesn't wash her hands. Not surprising. She walks down the hall, and she's holding her walker in the handrail, and I think visually I can see this patient. She goes to the lobby, and she sits down, and two other residents walk down the hall, and they touch the handrail because that's how they ambulate. Another resident, a visitor, or a staff pushes Marge's walker to the side so that no one trips on it, touching the contaminated surface. When Marge goes to the dining room, another resident sits in the chair. So you can see how difficult it can be in our long-term care environment to manage C. diff. We have to manage not only the patient themselves, but also patients' families, as there can be substantial resistance to having your loved one in isolation, to gloving and gowning, whether it's a visitor or nursing staff or other clinical staff or any staff coming in, because it changes the sense of their home to a clinical setting. If you're using bleach to decontaminate, that smell may be uncomfortable for people, and you may get complaints about that. And so you have to balance the dignity of the patient. You can't force a patient to wash hands. Showering and bathing can be a huge challenge. So all of these things can contribute to the difficulties that we have in C. diff. But an awareness of what is best practice, and a discussion with families and staff regarding how to do this, and with the patient as they're able with how to do this and the importance of doing this is important. So being, again, thoughtful about how you're treating this patient, ensuring that dignity is paramount, but at the same time ensuring the safety and the protection of those patients and family members and visitors around a patient with C. diff are important. So it's key to have a discussion with staff, with family, and to have a plan in place for how to manage C. diff infections. I read this little scenario and went, oh my gosh, it's such a common scenario that I think all of us can picture in our minds exactly this happening. Dr. Sanders?
I agree. I think that is the way we contract, the way we spread C. diff is something that we really need to think about and how we are moving around the facilities, whether it's post-acute, long-term care, acute care hospitals, the LTACs, is very important to think about that. I love that scenario. Anyone has any questions? We do have plenty of time for discussions, and I'll check to see if there's anything in the chat box.
All right, this is Dr. Levine. Did the guidelines talk anything about UV light? Because there's some good evidence that UVC light, ultraviolet C light, can disinfect and reduce C. diff by 25%. Did they mention that at all? These machines that actually sterilize rooms and lower the risk?
They do talk about the terminal cleans, and if you'll bear with me, I will find that. They do talk a little bit about terminal cleans and and I think you're speaking specifically to robotic terminal cleans.
Right.
And so let me, if you'll bear with me while I find that page, because I'm actually looking for it, and Dr. Sanders, if you find it first. Let's see. They say, what is the role of automated terminal disinfection using a method that is sporicidal against C. diff? And that's, if you have the paper, we'll be sending it. That is question number 22. And what they say is that there are limited data at this time to recommend use of automated terminal disinfection using a sporicidal method for C. diff, the CDI prevention. So I think that speaks to the robotic automated terminal disinfection, because I've seen those look really cool, but they were unable to give a recommendation with the current data that they have.
Got it. Another question, if I can ask. I don't want to give it, but one of the issues I have is that we keep people isolated, and generally in hospital and nursing homes, the rooms get cleaned when the patients get moved or cleaned, but there's spores all over that room while the patient's in there. So they'll keep someone in isolation. They maybe discontinue isolation, but they don't. Oftentimes, in the hospital, they don't terminally clean the rooms until someone else goes into that room. And I think it needs to be cleaned beforehand so you don't have them reinfect themselves. But I don't know if there's any guidelines that, when the diarrhea stops, that the room needs to be cleaned then and not when the patient leaves the building or not when he gets moved back to someone else and then when someone else goes into the room. You know what I'm saying? While they're still there.
No, I think that's a great point.
And I'm so glad that you asked that because, in fact, question 23 goes to that in the guidelines. It says, what's the role of daily sporicidal disinfection? So that's exactly, I believe, is the question you're talking about, right?
Right. Yes.
Daily cleaning with a sporicidal agent should be considered in conjunction with other measures to prevent CDI during outbreaks or in hyperendemic settings, or if there is evidence of repeated cases of CDI in the same room. And that's a weak recommendation with a low quality of evidence.
Okay.
So it's kind of saying that if you're suspicious about the room or it's hyperendemic or you have a C. diff outbreak, then you should be thinking about daily cleaning. That's when they're encouraging it. They don't comment on this, what I think you're speaking to, which is just an isolated C. diff case in their room because they
take them out of the room for a minute and go in there and just once their diarrhea stops, just to prevent that. Because I think they just reinfect themselves. That's why the long courses work because eventually the spores are hopefully disappear and die and go away. But
exactly.
But usually I find the diarrhea gets better. It's rare that you need a long course of treatment. It's just that they get reoccurrence. But I don't think it's because we didn't get rid of it the first time. It's because the spores are in the room and they're just keep reinfecting themselves with the handles and the doorknobs and the handrails and everything else. And if you could get rid of that source, then maybe we wouldn't have to do these recurrent treatments all the time.
And so I think that what you're speaking to, if there is evidence of repeated cases of CDI in the same room, so that's kind of what you're speaking to, is that the recurrence
or a
is
patient
happening
that gets
because they're in the same
recurrent.
room.
So he's good.
Right.
We treat him, we stop the antibiotic, and 3 or 4 days later he's got C. diff again because the room's never been cleaned. Terminally cleaned, but really cleaned properly, and the spores are all over that room. So
I think what you're speaking to is a very interesting study about infection prevention, and I think that will be a very different way of looking at this, and will make for an interesting study.
Right.
Yeah, I'd really like to sort of have a sense of what the spore burden is post-resolution of diarrhea in our population. I think in a healthy population that is able to perform appropriate hand hygiene and appropriate personal hygiene, and it may be very different from our population.
Mm-hmm.
Right.
Hi, Dr. Sanders.
Yes.
This is Maria. We have one of the patients that is going through the first recurrence of the C. diff infection, and he's being treated by infection disease in a prolonged vancomycin treatment, actually with the 250 milligrams. So patient has been almost for 4 weeks, and he has 2 more weeks, prescription for vancomycin. But my question is, we did repeat the stool, and it came back negative. Now patient doesn't have any more diarrhea, no more loose stools. But it was another roommate in that room that also had an infection, C. diff, before the patient was transferred to that room. So should we continue with the isolation to the end of the treatment, or it will be any indication that we can at least discontinue isolation and continue the treatment for the patient?
The second patient in the room has a C. diff infection. Is what you're saying? There's 2 people?
It was at one point, but they moved the patient, the other patient. Yeah, but so the
patient who you have who's on the taper could be safely reintroduced into another room because there's no more diarrhea. I do think they should continue to taper. In that case, I don't know if they need to. The recommendation is not for them to stay at the 250 dose, so that may be something you could talk to ID about, maybe going down to the 125. But if the person had an active infection with continued diarrhea, then that person needs to remain in isolation until 48 hours after the diarrhea has resolved.
So could vancomycin P also affect the renal function, because it has been something worsening on this patient as well? And so I can see the GFR going down and some creatinine raising up as well.
So, I have not heard of oral vancomycin impacting the kidneys. Dr. Novelli, have you heard of that?
I haven't, but it certainly wouldn't be out of the realm of possibility. But I haven't heard about this.
Yeah. I think what I would be more worried about is the hydration status of the patient.
Right.
Yeah, making sure that they're getting enough fluids.
Yeah, so we are encouraging by nursing plus the additional fluids with the tray, but it's still, and meals, but it's still, I see that happening on this patient.
Yeah.
And this is a good time to look at all other medications as well and see what else they bear on.
I agree with
and
that.
See if there's any other issue that's going on. And I'm just looking to see if it's renal insufficiency. I think if you look hard enough, there's renal insufficiency associated with any drug. So
this is Dr. Levine.
Yeah,
just to clarify, I just did an internet scan, and there's apparently, I think you're absolutely on the money. The renal function goes up because of the dehydration you get from the diarrhea and the C. diff. But there was one study that showed they actually measured low levels of it doesn't get absorbed through the gut. That's why we use PO vancomycin, so it shouldn't cause renal function abnormality. If the gut is severely damaged from C. diff, you're giving very ultra-high doses of vancomycin oral. They've measured concentrations one time, and there's a report of measuring concentrated vancomycins in the bloodstream, but typically it doesn't get in the bloodstream at all. And that was just an isolated report. Yeah.
And so you worry about the nephrotoxicity with IV vanc.
Right.
Yes.
Not with the PO. It shouldn't be a problem.
Yeah, PO, because it's not in that system. But I'm sure that there are case reports of it, so you can't isolate it, and it may be dosage dependent. So, as I said, and thank you, Dr. Levine, for that.
Yeah.
It's always something to worry about.
I just have a comment. I'm so glad to mention.
Yes.
This Dr. Levine, just one more last comment. That I've worked in hospitals too, and I can't tell me how many times they bring trays to the patients and leave them on the table. And there's no recommendation to hand wash. The patient just gets their tray and they walk away. And I'm just thinking, oh my gosh, you need to bring a towel and a leaf, so if they can't get out of bed, give them an opportunity to wash their hands. A warm white washcloth or soapy washcloth, so it makes, just to have this as a regular practice in nursing homes and hospitals, where there's access to washing your hands because they can't always get out of bed. And there's not usually, sometimes a good nurse will do that for them, but typically they put the tray down and walk out, and the patients eat on their own, and their hands, God knows what's on them. And they just keep reducing infection or spores or whatever to their bodies. So we have to do a better job of making sure our patients' hands are washed before they eat.
Definitely agree. I thank you all for joining. Thank you for all the great comments. Thank you, Dr. Levine. Thank you, Dr. Novelli, who is our wonderful founder of FMDA Journal Club. This session has been recorded. It will be available as a podcast. If you know anyone who has missed it and want to listen to it, please let them know. And I'm sure Ian and Jordan will be sending out reminders of that as well. Thank you, everyone.
Thank you so
Have
much.
a great day. Thank you.
Thank you.
Bye-bye.
Bye. Thank you. Bye.